Καλησπέρα σε όλους. Ελπίζω να ακούγομαι. Με την ιδιότητα του Προέδρου του Ελληνικού Δικτύου Διαβήτη στην Πρωτοβάθμια Φροντίδα Υγείας, του Ταμεία του Primary Care Diabetes Europe και του Προέδρου του σημερινού webinar, σας καλωσορίζω απόψε στο webinar μας, το οποίο είναι το τελευταίο για το 2022 και γι' αυτό το λόγο παρακαλώ επιτρέψτε μου να κάνω ένα πολύ σύντομο απολογισμό της χρονιάς, προτού σας παρουσιάσω τον σημερινό μας ομιλητή. Όπως γνωρίζετε, το Ελληνικό Δίκτυο Διαβήτη αναπτύσσει μια σειρά εκπαιδευτικών πρωτοβουλειών, η αρχή των οποίων συνίσταται στα μηνιαία αυτά webinars που λαμβάνουν χώρα το βράδυ κάθε Τρίτης Δευτέρας του μήνα, με μια σειρά θεματολογιών και ομιλητών που αντλώνται εντός εισαγωγικών από την Πρωτοβάθμια Φροντίδα Υγείας και άπτονται, εκτιμώ, των ενδιαφερόντων των επαγγελματιών υγείας στην Πρωτοβάθμια Φροντίδα Υγείας. Είναι δηλαδή ειδικά σχεδιασμένα για αυτήν, κάτι που τα διαφοροποιεί από τα υπόλοιπα που υπάρχουν. Και ήθελα να ευχαριστήσω πάρα πολύ το κοινό μας, το οποίο αγκάλιασε από την πρώτη μέρα διεξαγωγής σε αυτά τα webinar, παρά την πληθώρα των διαδικτυακών μαθημάτων, από την οποία όλοι κατακριζόμαστε. Και η σημαντική αυτή παρουσία σας μας δίνει ιδιαίτερη δύναμη και χαρά να καταρτήσουμε το πρόγραμμα του επόμενου έτους, το οποίο έχει αναλάβει να φέρει εις πέρας ο υπεύθυνος της Επιτροπής Εκπαίδευσης του Δικτύου και ο έμπειρος συνάδελφός μας, κύριος Τσακουντάκης, από την Κρήτη, σε συνεργασία βέβαια με τα υπόλοιπα μέλη της Επιτροπής Εκπαίδευσης και του Διοικητικού Συμβουλίου. Παράλληλα, το δίκτυό μας ήδη μετρά 2 συμμετοχές στις εκπαιδευτικές ημερίδες Πρωτοβάθμιας Φροντίδας Υγείας Παπαδάκη, με δικά τους στρογγυλά τραπέζια. Στο τελευταίο, μάλιστα, δόθη ιδιαίτερη έμφαση στη διαχείριση του διαβήτη στην καθημερινή κλινική πρακτική, στην Πρωτοβάθμια Φροντίδα Υγείας. Θα ήθελα επίσης να σημειώσω ότι πάρα πολλές ακόμα καινοτόμες εκπαιδευτικές δράσεις ήδη σχεδιάζονται για το 2023 και ελπίζω πολύ σύντομα να οριστικοποιηθούν, να επισημοποιηθούν, για να μπορώ να σας τις αποκαλύψω. Και σε όλες αυτές τις δράσεις, η παρουσία και η ενεργό συμμετοχή όλων των μελών μας, από όποια θέση δύναται και επιθυμεί να αναλάβει ο καθένας, είναι πολύ παραπάνω από απλώς επιθυμητή. Και γι' αυτό το λόγο και προσκαλώ με την ευκαιρία του απόψινού webinar όποιον ενδιαφερόμενο επιθυμεί να συμμετέχει, να εμπλακεί στις δράσεις του δικτύου, να απευθυνθεί σε μένα ή στον κύριο Τσακουντάκη στα πλαίσια της εκπαίδευσης. Στον τομέα επίσης έρευνας έχουμε ήδη ένα ερευνητικό εγχείρημα σε εξέλιξη που περιλαμβάνει δημιουργία, αξιολόγηση και πιλωτική εφαρμογή δικτών διαχείρισης ποιότητας φροντίδας για τους ασθενείς με διαβήτη τύπου 2 στην Πρωτοβάθμια Φροντίδα Υγείας. Ένα μεγάλο εγχείρημα που συμμετείχαν πολλοί επαγγελματίες υγείας και ερευνητές από χώρες της Νοτιού Ευρώπης και φυσικά και εκ τα μέλη του δικτύου μας. Είχα την τιμή να παρουσιάσω τα πρώτα αποτελέσματα στο συνέδριο του EGPRN. Στο EASD επίσης παρουσιάστηκαν κάποια επιπρόσθετα ευρήματα και ευελπιστούμε σύντομα να ακολουθήσει και η ξενόγλωση δημοσίευση. Και εδώ πάλι προσκαλώ οποιονδήποτε ενδιαφερόμενο να ενταχθεί στην Επιτροπή Έρευνας, ούτως ώστε να ενδυναμώσουμε τις ερευνητικές μας δράσεις. Και σε κάθε περίπτωση η παρουσία και ενεργό συμμετοχή οποιοδήποτε από εσάς στις δραστηριότητες του δικτύου, θέλω να τονίσω ότι αποτελεί μια αμφίδρομη σχέση στήριξης εσάς προς το δίκτυο, αλλά και του δικτύου προς εσάς και επακολούθης προβολής του επιστημονικού έργου του κάθε συμμετέχοντος μέσω του δικτύου και φυσικά όλο αυτό οδηγεί εν τέλει και στην ενδυνάμωση της φωνής των επαγγελματιών υγείας στην Πρωτοβάθμια. Και γι' αυτό το λόγο σας προτρέπω και πάλι να διερευνήσετε ο καθένας από εσάς τη δυνατότητα συμμετοχής στις δραστηριότητες του δικτύου που δεν περιορίζονται όμως μόνο σε όσες πολύ επιγραμματικά ανέφερα. Κλείνοντας την εισήγησή μου αυτή και επανερχόμενος στο θέμα των webinars, από όπου και ξεκίνησα, όπως ξέρετε, το Ελληνικό Δίκτυο Διαβήτη στην Πρωτοβάθμια Φροντίδα Υγείας επέλεξε για φέτος, την πρώτη χρονιά των διαδικτυακών του μαθημάτων, να προσκαλέσει τιμητικά στο πρώτο και τελευταίο webinar της χρονιάς 2 εμβληματικούς καθηγητές της Πρωτοβάθμιας Φροντίδας Υγείας. Στο πρώτο webinar είχαμε τη χαρά και τιμή να φιλοξενήσουμε τον πρόεδρο του PCDE, τον καθηγητή Ξαβδιακός, ενώ στο απόψινό webinar θα έχουμε και πάλι τη χαρά και τιμή να φιλοξενήσουμε τον καθηγητή Σαμουέλ Σέιντου, που είναι αντιπρόεδρος του PCDE και υπεύθυνος του τομέα της έρευνας. Το PCD, για όσους δεν το γνωρίζουν, είναι η Ευρωπαϊκή Εταιρεία για το Διαβήτη Πρωτοβάθμια Φροντίδα Υγείας, μια εταιρεία που μετρά περίπου 30 χρόνια πλούσιας δράσης σε επίπεδο έρευνας, εκπαίδευσης, αλλά και προαγωγής της φωνής των επαγγελματιών πρωτοβάθμιας φροντίδας υγείας σε ευρωπαϊκό επίπεδο. Ενδεικτικά σας αναφέρω μόνο το κορυφαίο εκπαιδευτικό δρόμο του PCDE, που είναι το πανελλήνιό του συνέδριο που διεξάγεται αναδιετία στη Βαρκελόνη και που αποτελεί πόλο έρξης ομιλητών παγκοσμίου βεληνικούς, όπως η καθηγήτρια Μέλανι Ντέιβις και ο καθηγητής Κάμλες Κούντι, που είναι ερευνητές καθηγητές που συμμετέχουν στις μεγαλύτερες μελέτες παγκοσμίως στον τομέα του σαχαρόδου διαβήτη, αλλά και ως συγγραφείς κατευθύνων οδηγιών σε ευρωπαϊκό και αμερικάνικο επίπεδο. Το επόμενο συνέδριο του PCD θα διεξαχθεί τον προσεχή Ιούνιο στη Βαρκελόνη και πραγματικά θα είναι πολύ μεγάλη μου χαρά να διαπιστώσω πολλές ελληνικές συμμετοχές. Ο απόψινός μας λοιπόν ομιλητής είναι ο καθηγητής Σάμουελ Σέιντου, ο οποίος θα απευθυνθεί για πρώτη φορά στο Ελληνικό Ιατρικό Σώμα και θα παρουσιάσει μια πρακτική προσέγγιση στη διαχείριση του σαχαρόδου διαβήτη τύπου 2 στην πρωτοβάθμια φροντίδα υγείας, βασισμένη στο PCDE Position Statement, του οποίου είναι και ο κύριος συγγραφέας. Ο καθηγητής Σέιντου είναι κλινικός καθηγητής στο σαχαρόδου διαβήτη στην πρωτοβάθμια φροντίδα υγείας και στην καρδιομεταβολική ιατρική στο Πανεπιστήμιο του Λέστερ στο Ηνωμένο Βασίλειο, που είναι συνδεδεμένο με το Leicester Diabetes Center, το μεγαλύτερο ίσως διαβητολογικό κέντρο στην Ευρώπη. Αυτή τη στιγμή είναι ο αντιπρόεδρος για την έρευνα του PCDE, είναι μέλος του Διοικητικού Συμβουλίου της Διαβητολογικής Εταιρείας Πρωτοβάθμιας Φροντίδας του Ηνωμένου Βασιλείου και επί του παρόντος κλινικός επικεφαλής και μέντορας για το διαβήτη στην ευρύτερη περιοχή του Leicester του Ηνωμένου Βασιλείου. Το 2021 έλαβε τον τίτλο του πιο εξέχοντα ερευνητή πρώιμης σταδιοδρομίας από το Royal College of General Practitioners, ενώ είναι και Associate Editor του περιοδικού Primary Care Diabetes. Αγαπητοί συνάδελφοι, το ερευνητικό του έργο στον τομέα της σαχαρόδου διαβήτη στην πρωτοβάθμια είναι εξαιρετικά πλούσιο. Μας τιμά πολύ που είναι γενικός γιατρός ο ίδιος και αυτό το έργο δεν μπορεί να περιγραφεί πραγματικά στο λίγο χρόνο που έχω στη διάθεσή μου. Θα είναι όμως πολύ μεγάλη μας χαρά και τιμή να τον έχουμε απόψε κοντά μας και να μας μιλήσει ο ίδιος. Και τώρα επιτρέψτε μου να συνεχίσω στα αγγλικά και να καλωσορίσω τον καθηγητή. Tonight we are privileged to host Professor Samuel Seydoux, who is clinical professor in primary care diabetes and cardiometabolic medicine at the University of Leicester. He is currently the Vice Chair for Research for Primary Care Diabetes Europe, board member of the Primary Care Diabetes Society of UK, and also currently clinical lead and mentor for diabetes in the Leicestershire and Rutland Integrated Care System. In 2021, he was named the most outstanding early career researcher by the Royal College of General Practitioners. He is a practicing Leicester City general practitioner, a partner, lead undergraduate tutor, and GP trainer at the Hockley Farm Medical Practice, and an associate editor of the Primary Care Diabetes Journal. I hope I haven't forgotten anything important. Professor Seydoux is going to present us an evidence-based and really practical approach to type 2 diabetes management, really tailored to primary care particularities and needs, which is in fact based on the PCDE position statement. Respected Professor Seydoux, dear Sam, your presence is a true honor for the entire Greek GP audience. Thank you so much for being here with us tonight.
Thank you. Thank you for a very kind introduction, Philip. I'll just share my slides if that's okay. Okay. Can you see my slides all right?
Yes.
Okay. Let me just do that. Right. Is that the right mode for you? Is that okay for me to present in this mode? Yeah?
Yes.
Okay. Right, so the agenda for today is I'm going to spend a bit of time talking about the background and rationale for us developing a primary care specific position statement, and I'll do a bit of categorization on the risk phenotypes of type 2 diabetes from the primary care perspective. I will talk a little bit about some evidence that supports the decisions that we've made. And then I would spend the last few minutes talking about the consensus recommendations themselves. And then we can stop there and take some questions and answers. So the position statement aims to be used to address the whole patient, not just their diabetes, but everything else: their weight, their cardiovascular risk, their age, their multimorbidities, kidney failure, heart failure, everything that comes with it. Because in the primary care, these are the sort of things that we worry about. We don't just worry about the A1Cs. We also want to make it very practical for the choices of drugs to be used, because there's so many options. And sometimes trying to navigate your way through the various options can be very confusing. We'll define the various phenotypes, and then we'll do the evidence-based recommendations. So this was not just a group of specialists who decided to put down what they think should be implemented across primary care, but we selected, the faculty consisted of experienced GPs, key opinion leaders and researchers in primary care diabetes from North America and Europe, who came together, and all the participants had to debate all the decisions that we had to make in arriving at the consensus recommendations. We had a specific methodology, and we had to, agree on a Likert scale of all the questions that we had to address. And we divided responses into strongly agree or disagree, disagree, agree, and strongly agree. And if there were any outliers, we gave them the opportunity for them to bring further evidence for us to debate. And then we voted again, and the vast majority of people had their opinions heard. We had an external facilitator. We did not use our own team to facilitate. So the external facilitator made sure that there was moderate dialogue between the participants, and nobody was driving the whole agenda based on their experience. They maintained, the agenda based on what we agreed to discuss and resolve all the conflicts, and created a very positive environment. And all voices were heard. There was no coercion by any strong personalities. The predefined questions in coming with the position statement were very consistent across all the drug classes. The first was, what is the drug class and what options are available within that class? So for example, if you talk about GLP-1 receptor agonists, what's the evidence in diabetes and what are the options within that class? The second was, what is the current evidence that supports the use of each drug within the class to prevent recurrent cardiovascular disease? And also, are there various options that you would prioritize within that class, and any additional information? And so by the additional information, we're not just talking about cardiovascular diseases, we're also talking about other issues that confront us in primary care, such as weight loss, multimorbidity, age, and so on and so forth. The main drivers for the decisions in the consensus report were, one, simplicity. We also looked at multimorbidity. We addressed therapeutic inertia, and then patient safety. So these were the main drivers which we think are the issues that confront us in the primary care setting. So first of all, simplicity. This is how the consensus report looks like. The algorithm is one pager. We don't want a lot of pages for you to be flipping through because we haven't got the time. So with this, you can have a laminated copy in your consulting rooms, and that will give you a guide. So that's basically what it is. And we have three sections: those who have very high risk of cardiovascular disease, those at high risk of cardiovascular disease, and obese patients. And then finally, we have the elderly patients over the age of 65. This is another way of looking at the algorithm in a more pictorial form. So those patients at very high risk includes patients who are who have established atherosclerotic cardiovascular disease, patients with heart failure, patients with chronic kidney disease, and patients under the age of 40. I'll say that again. Those patients at very high cardiovascular risk include those with atherosclerotic cardiovascular disease, heart failure, chronic kidney disease, and patients under the age of 40. Every other person with type 2 diabetes is at high risk. So this method of classification of type 2 diabetes phenotypes, in my opinion, is a very simplified approach for the primary core audience. We only have two risk categories, those at very high risk and those at high risk. If you compare this algorithm with the ESC algorithm, they have three categorizations: patients at very high risk, at high risk, moderate risk, and low risk. Now, we have too many things to think about in primary care. So if you do have several classifications, it's just going to be too confusing for us to be able to follow. And that's why we don't believe there's anybody with type 2 diabetes who is at low risk of cardiovascular disease. All patients with type 2 diabetes are either at high risk of cardiovascular disease or very high risk of cardiovascular disease. High risk of very high risk of cardiovascular disease, atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease. We know that these patients are more likely to get recurrent cardiovascular disease. And so you have to treat them very intensely to prevent recurrent events. We included patients under the age of 40 in this group, not because they are more likely to get recurrent cardiovascular disease, but because there is evidence that shows that a patient who is young, under the age of 40, who develops type 2 diabetes has a very aggressive phenotype. They have a very aggressive form of the disease. A lot of them would have complications even at the time of diagnosis. And given that this age group is the working age group, these are the patients who have young children to look after, who look after elderly relatives, and who are the working class. Any diabetes complication or worse still death has a huge knock-on effect on the whole society. And so for that reason, we thought that there is a societal need for us to class them as being at a very high risk of cardiovascular disease so that we can give them a more intensive and aggressive treatment and prevent them getting complications. For those patients who are at high risk, we have, the obese patients within that group, and those with, other cardiovascular risk factors. All of them are in that group. The elderly population, we kind of took them out of the risk stratification for cardiovascular disease, not because we think elderly patients do not die from cardiovascular disease, but we sort of think that for the elderly frail patient, their goal of treatment usually is not so much about avoiding complications. It's not so much about avoiding, cardiovascular disease or, in fact, death. A lot of them are more concerned about a good quality of life, living, life without pain. And so the goals of treatment, you have to choose your drugs carefully, not necessarily going for drugs that will prevent heart failure or chronic kidney disease, because that is the least of their worries in most instances, but choosing a drug that will give them a good quality of life, i.e. they do not get side effects from those drugs and don't have to wake up several times with side effects. So that's the reason why we kind of took them out of the categorization. So that's the way of categorization. So now moving on to the reasons why, the evidence base for, the suggestions that we made. And I'll start off by talking about multimorbidity. Like I said, in primary care, we don't only treat patients with diabetes, we treat patients with a lot of other complications. And other conditions, long-term conditions. So this is looking like a very busy slide, but it's actually very easy. This just basically is saying that patients in this table, the percentages in the table represent the percentage of patients with the row condition that also have the column condition. So for example, if you take patients with coronary heart disease, 23% of them will also have diabetes. 54% of patients with hypertension will also have diabetes. And indeed, it's only 7.6% of patients who have only diabetes. The vast majority of patients will have type 2 diabetes and something else. And if you are over the age of 65, you will have a mean of 6.5 other conditions in addition to diabetes. And if you are younger than 65, about 3 other conditions in addition to diabetes. So we have a lot of problems to deal with in primary care. So when you are choosing your drug, you don't just choose based on diabetes, we choose a drug based on all the other long-term conditions that they have. It affects our consultation rates. Multimorbidity affects our consultation rates. So this is data that we published earlier this year for the Leicester Diabetes Center, looking at the consultation rates in patients with type 2 diabetes with and without vascular complications. And what you see here is that over the past 2 decades, between 2000 and 2018, there has been a 50% decline in the consultation rates for patients with type 2 diabetes and cardiovascular disease. And for patients with just type 2 diabetes alone, there has been a 45% decline in the consultation rates. On the contrary, there has been a steady increase in the consultation rates in secondary care, with 33.3% of patients with type 2 diabetes and cardiovascular disease being an increase over the past 2 decades, whereas the increase was 54.4% in patients with type 2 diabetes alone in secondary care. Now, we, in this paper, did not look at the reasons for this decline, but I suspect that we're taking our foot off the pedal because primary care is supposed to be managing 90% of all the cases, but the consultation rates is decreasing. It may well be the case that other acute illness such as coughs and colds and back pain and so on are taking our time of these long-term conditions. The consultation duration, though, has increased. Even though the consultation rates have decreased in primary care, the length of time that we spend with one patient in primary care has increased by about 70% with GPs and 79% when you're looking at the nurses. So even though we are seeing less patients, we're spending longer time, which is good because you then get to spend more time with the diabetes and the cardiovascular conditions in the same consultation. When you have multimorbidity, cardiovascular multimorbidity, cardiometabolic multimorbidity is a big issue in diabetes. Indeed, in the 21st century, I would say that diabetes, heart failure, and chronic kidney disease are the 3 pandemics in the 21st century. This is data that we published again earlier this year, looking at the 3 conditions. And here we looked at patients with new diagnosis of heart failure. And then we looked at the trends in 1-year rates of all-cause hospitalizations. And what you find is that over the past 2 decades, the 1-year rates of all-cause hospitalization was decreasing in patients with heart failure alone or heart failure with diabetes. Now, once you throw chronic kidney disease into the mix for patients with heart failure, type 2 diabetes, and chronic kidney disease, that decrease over the past 2 decades attenuates. So chronic kidney disease is bad news. Once you have chronic kidney disease, you actually decrease the survival of the patient. Patients with heart failure alone, the mean survival over 10 years in this paper was found to be about 4.4 years, and heart failure and type 2 diabetes for 4.2 years. But for heart failure, type 2 diabetes, and chronic kidney disease, you only are expected to live another 2.2 years. And depending on the severity of chronic kidney disease, for patients with chronic kidney disease stage 5, if you have those patients with heart failure and type 2 diabetes, from this data, their mean survival is only 6 months. And so multimorbidity, cardiovascular multimorbidity is a big issue in primary care for us. How about therapeutic inertia? This was another big driving factor for our consensus recommendation. And we know that inertia is a big deal. There are several causes of therapeutic inertia. Inertia is our failure to intensify or initiate treatment when it's appropriate to do so. And these causes can be related to the patients due to adherence and side effects issues, or healthcare professional related, which accounts for about 50% of all the causes of therapeutic inertia. And finally, the healthcare systems. So if you are working in Greece, for example, you might say, I don't know Greece, but it might be the case that primary care is not allowed to prescribe certain drugs. So if the patient actually needs it from our consensus report, you still cannot prescribe it. So that accounts for about 20% of all the causes. But the vast majority of the causes of therapeutic inertia are caused by the healthcare professional. Competing demands, lack of knowledge, variations in guidelines, communication barriers, and a lot of other reasons. So we put forward all these excuses, and that prevents us from initiating or intensifying treatment when it's appropriate to do so. In this paper, we looked at ethnic and social and multimorbidity disparities in therapeutic inertia. What we found was that the longest delays in prescribing first-line drugs for patients with type 2 diabetes were old age, over the age of 60 years, and Black patients. So these are the two big issues that prevent clinicians from starting first-line drugs. In the same paper, we noted that the median time was 0.5 years or 6 months for starting a first-line drugs, 4.1 years for starting a second-line drug, 4.6 years for starting a third-line drug, and 4.7 years for starting a fourth-line drug. After type 2 diagnosis, 25% of patients in this cohort develop cardiovascular disease or non-cardiovascular complications within a follow-up period of 12 to 14 months. And during that follow-up period of 12 to 14 months, intensification was received 5 to 6 years later. So therapeutic inertia is a big deal. So from the UK PDS that if you've got patients who are newly diagnosed and you treat them intensively, you do get good prevention of complications, microvascular complications, and in the long run, macrovascular complications as well. And we also know that there is a legacy benefit for doing so. But it's not just controlling patients very early, intensively. So in this simulation paper that we published in 2019, what we did was assume patients in primary care were recruited with the UK PDS sort of demographics, and you manage to control their A1C down quickly and maintain it well controlled, smoothly, without any undulation of A1C or variations, you initially will prevent the microvascular complications, but then later you prevent macrovascular complications. So this is what UK PDS tells us. But it's not just controlling the A1C well early and maintaining it very low. It's also avoiding glycemic variations. If you control your A1C down and 3-6 months later it goes up again because you only start with metformin, and then another 3 months later it comes down again, and then you add glycoside or GLP-1 receptor agonist or whatever, and the A1C comes down, it goes up again, and then you add insulin, and that seesaw approach is also associated with high cardiovascular risk. So you want to avoid the seesaw approach. What you want to do is get a smooth control very early on from diagnosis and maintain that control for as long as possible. Which means that if you get your patient who is, say, under the age of 40, you control their A1C very quickly with whatever you have, keep it down and prevent it from offshooting. Don't allow the A1C to go above their target of, say, 6.5%, maintaining below that level for as long as possible, and you prevent all the complications. How do you do that? At the moment, this is how we do. We start with diet and exercise. A1C comes down, we add metformin. A1C comes down, about 3-6 months later, it goes up again, and we add sulfonylurea or GLP-1 receptor agonist or whatever you use in your country. The A1C comes down again, and then you wait another 3 months, it goes up again, and you add, you keep doing that. So that's not good. So what we are advising in this consensus report is that you hit your patients very hard from the diagnosis, move that curve more to your right, and keep it very low for as long as possible to prevent complications. If you do that, what you will show is that you prevent complications. So this is a study that my colleague Kamlesh Kunti led from the Leicester Diabetes Center a few years ago now, about 5 years ago. And he looked at 104,000 patients newly diagnosed with type 2 diabetes in the UK primary care database, and compared those who had poor control of glycemia within the first 12 months, and that was 26% of the population, with the rest of the population. So those patients who had good control within the first 12 months, below A1C of 7, comparing them to those who had poor control after the 12 months, they didn't get their A1C below 7 after 12 months. And you follow these two cohorts of patients for 5 years. What you found was that at the end of the 5 years, there was a 67% increased risk of myocardial infarction, 51% increased risk of stroke, 64% increased rates of heart failure, and the composite cardiovascular event was increased by 62% just by following these patients up. So the idea is to avoid, this delay in controlling glycemia, get it down quickly below 7% and maintain that for as long as possible. If you don't, you get this, shaded area in the curve, and that is what we call the dysglycemic legacy, and it's what is driving all the complications in type 2 diabetes. So what we're doing now in primary care is using a multifactorial approach: glycemic control, lifestyle interventions, blood pressure control, and lipid control. So that is all very good. So keep doing that, don't stop, do that very early. But these are very difficult to achieve. So you may have to do several drugs to achieve this. So if you got a drug that can tackle a lot of these at the same time, probably it would be a useful thing to do that in one go because you're a very busy clinician. It's not just about focusing on cardiovascular disease. Focusing on weight is also a good idea. So this is a simulation study that was published in JAMA earlier this year. And they looked at the potential gains in life expectancy associated with achieving treatment goals in the US population of patients with type 2 diabetes. And what they found in this study was that compared to patients who have morbid obesity or obesity class 3, lower BMI of patients who have normal BMI of, say, 23 compared to overweight patients or obese patients were associated with 3.9 years, 2.9 years, and 2 years additional life expectancy, respectively, in patients with type 2 diabetes. So controlling the weight also actually makes you live longer. It's not just about cardiovascular disease. The next thing to talk about is the next thing that drove our consensus recommendations was early combination therapy to avoid therapeutic inertia. So the data evidence is increasing in this area. This is a systematic review that was published earlier about 8 years ago. 50 randomized controlled trials looking at combination therapy with metformin, which provided statistically significant reductions in A1C and actually attainment of treatment goals. The verified trial, which is the latest one in this area, also looked at early combination therapy with etildagliptin and metformin, compared with stepwise approach that we normally do. And they also showed good reductions in treatment failure in the intervention group. This was preceded by the EDIC trial which was led by Ravi Fronzo in the Middle East. And they looked at combination of metformin, pioglitazone, and exenatide, and that was more effective than sequential additions of medications. And indeed, side effects in this trial were also less than in the stepwise approach. So based on all this evidence, we now recommending initial combination therapy, and I'll come back to that later. The data that I've shown here is all about surrogate markers, A1C reductions, and side effects. So earlier this year, we tried to look to see whether combining medications early in type 2 diabetes was associated with prevention or reductions in cardiorenal outcomes, not just A1C, but cardiorenal outcomes. And what we found in this study was that the studies looking at this topic are very scanty indeed. So there is a lot of research that is needed in this area, but a few studies that we got to do this analysis did not show a statistically significant difference between the two groups. However, we did see a reductions in A1C and indeed, glucose measurements by other methods. And side effects profile were also better in the initial combination therapy in this analysis. So based on all this evidence and based on the justifications on the categorization of the diabetes phenotypes, these are the consensus recommendations from Primary Care Diabetes Europe 2022 updates. So first off, for patients at very high risk, focusing initially on the cohort of patients with atherosclerotic cardiovascular disease. What we are recommending is don't just focus on glycemic control, but then again, don't forget about glycemic control. So for patients with atherosclerotic cardiovascular disease, go for early combination therapy with metformin and a GLP-1 receptor agonist or an SGLT2 inhibitor in combination rather than stepwise. So patients with atherosclerotic cardiovascular disease, please, is early combination therapy with GLP-1 receptor agonist or SGLT2 inhibitor plus metformin. So the reason why I'm insisting on early combination therapy is for you not to focus only on cardiovascular disease prevention and forget about A1C reduction. Metformin may not have cardiovascular outcome data, but we know we have a lot of experience with metformin in reducing glycemia and preventing microvascular complications. And so initial combination therapy will ensure that as a primary care physician, you are not just focusing on preventing cardiovascular disease, but you're also preventing microvascular complications, retinopathy, foot ulcers, and so on and so forth. Of course, there are patients who will refuse to do this. They don't want to take too many pills at the same time. Or you work in an area where your local guidelines are in conflict with this, or you work in an area where they will not allow you to prescribe GLP-1 receptor agonists at the same time. So if you are in such an area or the patient is refusing to do that, of course, you can go by the patient's choice, in which case we'll recommend for glycemic control, I must underline that for glycemic control, your metformin should be first line. And then you can then add SGLT2 inhibitor or GLP-1 receptor agonist protein cardiovascular disease. That is for glycemic control. Of course, if you're concerned about cardiovascular risk reduction, then you would be choosing the SGLT2 inhibitor or GLP-1 receptor agonist first. But as a primary care physician, I would not choose one or the other. I would rather concentrate on all of them and try to educate your patient. We recommend not to rush to basal insulin. If you do, use that with caution, and we only consider that when the treatment options fail. Simply because of the side effect with insulin, weight gain and hypoglycemia, and also in the primary care setting, it's a lot more difficult for us to initiate insulin because it takes a lot more time to educate the patient properly. And there are other driving implications with hypoglycemia and so on and so forth. So still on the patients at very high risk of cardiovascular disease, the next subtype is patients with heart failure. So for a primary care physician, we're not separating heart failure into HFpEF or HFrEF. We're not interested. When you have a patient with heart failure, what we are suggesting is, again, don't forget about microvascular complications. So you do initial combination therapy with metformin and an SGLT2 inhibitor rather than a stepwise approach. And once again, if you do have a situation where the system or the patient will not allow you to do early combination therapy, of course, for glycemic control, metformin is your first line, and then SGLT2 inhibitor will be your second line therapy. However, if glycemic control is not what you're focusing on, but the heart failure, then of course, SGLT2 inhibitor will be your preferred option as a first line. But then again, why would you want to choose one or the other? I would recommend you focus on choosing both. As a primary care physician, do holistic care for this patient and treat them with early combination therapy. But at all costs, try to avoid pioglitazone and sitagliptin and use basal insulin only with caution. Similarly, for patients with chronic kidney disease, same sort of argument. Again, early combination therapy with metformin and SGLT2 inhibitor rather than stepwise approach. The same sort of argument. But remember that your metformin, your EGFR has got to be more than 30. And for your SGLT2 inhibitor, it depends on which one you are using. There are different license indications for all of them. But recently, the KDIGO guideline has suggested going all the way down to 20 for all of them, which I would concur with. But it's the same sort of approach. Now moving down to patients at high risk. So we've finished with those at very high risk. This is now for patients at high risk. That's basically the rest of your type 2 diabetes population. So here you can do exactly what you've been doing before, but remember to consider early combination therapy with metformin and an SGLT2 inhibitor, GLP-1 receptor agonist, DPP-4 inhibitor, or whatever you have in your country. Use combination therapy first. But the same argument goes, if you do have a situation where they are not allowing you to do combination therapy, your metformin should be considered first for glycemic control. Pioglitazone has some data on non-alcoholic fatty liver disease, so we recommend that you should consider that. Obesity is a big one. I showed you the data about life years gain from that modeling study in America. It's not all about cardiovascular disease. So for patients who are obese, and that's the vast majority of our patients with type 2 diabetes, a combination of metformin and GLP-1 receptor agonist or SGLT2 inhibitor rather than a stepwise approach is what we recommend. If you do desperately need to use insulin, just because insulin makes you put on weight, you should consider an FRC, a fixed ratio combination of insulin and a GLP-1 receptor agonist. You've got Zoltofy from Novo Nordisk and Aglalicin, from Sanofi. Okay, so how about the elderly population? So, like I said earlier on, if you've got an older patient who is frail and you're concerned about quality of life rather than preventing complications of death, then of course, you're not worried about preventing cardiovascular disease. You should just avoid stringent glycemic control, avoid hypoglycemia. So metformin as first line, if not contraindicated, and DPP-4 inhibitors are very safe and easy to use in this patient population. And if you have to use insulin, try to use once daily insulin so that your housebound patients will use pair the carers and nurses, district nurses who visit these patients from making multiple trips to the patient's homes. So in conclusion and your take-home message, our position statement is meant to be a practical counterpart for what you have in Greece. It's not to replace your local guidelines, it's just to complement that. And we based our position statement based on evidence-based risk categorization of patients with type 2 diabetes. And there are key issues that we use to develop the consensus report, which are inertia, multimorbidity, and we use strategies such as early combination therapy to address some of these. The pharmacotherapeutics that we've suggested in the algorithm are evidence-based and should use them to supplement what you have in local countries. Thank you very much, and I'll take questions.
Thank you so much, Professor Seidu, for this excellent presentation, where you have provided us with a very clear strategy on how to effectively manage type 2 diabetes patients in primary care settings, with a lot of evidence, very robust evidence, that are coming from important studies and meta-analysis, and among other data coming from studies that you have performed yourself as well. I don't know if there are any questions from the audience before I start commenting or asking one or two questions myself. Υπάρχουν ερωτήσεις από το ακροατήριο σε αυτή τη φάση? Okay, so until we gather any questions, let me start by making a few comments and maybe ask one or two questions myself. So I was really impressed by this PCDE consensus statement, and especially by the time it was originally published, which was, I think, 1.5 years ago. Yeah. Which was a time where we didn't have the latest ADA EASD guidelines, yeah, and even more the latest ADA EASD consensus, which I think was maybe the first paper which was so close to primary care, closer than ever before. And many things that you stressed in your speech and that are included in this position statement have now been adopted, I think, by the ADA and EASD. Yes. So this advice, this evidence-based advice that you provided us, that get it down very early, I noted your exact words, I think is very important and is worth being really stressed towards our audience in order to effectively prevent complications. So this is something that I personally noted from your excellent speech. What also was very interesting to me is this age categorization, and both the very young and the elderly. Regarding those whose age is under 40 years, I understood what you said about the aggressive phenotype. It seems quite rational to me. On the other hand, I wonder why this same rationale has not been adopted in other guidelines or consensus statements.
Yes.
Why don't they see the evidence behind that?
Yeah. The other guidelines that you talk about, I mean, the ESC guidelines, they actually classified older age as high risk. And I think the evidence for that is based on the high risk of recurrent cardiovascular disease in the older population, which we know. But in primary care, what we are thinking is we are more holistic. The sort of patients we see is slightly different from patients seen by specialists. A specialist seeing you is very concerned about keeping you alive and preventing you from dying, preventing you from, getting complications. Whereas in the primary care, when I get you, yes, I am concerned about preventing you from dying and preventing you getting complications, but I'm also worried about, your family, what work you do, everything else, because when they come to tell us in one consultation, the patient comes to diabetes, but they're also talking about their depression and their financial problems and everything else. So if you put it all together holistically, you realize that it's not all about preventing recurrent cardiovascular disease, which is higher in the older age group. I get it. I agree. But when you put it all together, we think that those under the age of 40, given that they have a very aggressive phenotype, and this aggressive phenotype is very likely to get them incapacitated with a heart attack or stroke or kidney failure much earlier. There are MRI images that have shown this in patients with type 2 diabetes. We think that population needs to be protected. Every complication in diabetes is tragic. Every death in diabetes is tragic. If you are old and you get diabetes complication and you die, it's a tragic story. If you are young and you get type 2 diabetes complications, it's very, very bad. But if you are in that age below 40 where you have young people to look after and older family members to look after, and you are the one working to keep the health economy going, I think we just think that you've got to look after them properly. So I don't think in the next year or two, the other guidelines will change and follow suit. I'll pray they do, just like they did with the latest EAZ consensus report, because we talked about early combination therapy long before anybody else did. If they do decide to recognize young patients as very high risk, I think that would be a good move. But at the moment, we are the ones that are looking at it. The latest EAZ consensus report also alluded to this fact, but they did not classify them as a very high risk.
Okay, thank you very much for this nice clarification. And I do really hope that PCDE will also lead the way in this matter as well. Now, the other question I would like to ask again about age is the elderly thing. So I saw that, I noticed that the elderly and frail patients are categorized as lower cardiovascular risk compared to the others. So at high, maybe at high, but not very, very high. And the strategy in this patient is quite different.
Yeah.
So I would like to ask, how is elderly defined? Is it defined according to the classical definition of more than 65 years? And I'm asking this just because nowadays, a person who is 65 or 70 years old could be enjoying a very good quality of life, could be in an excellent health status. And would it be a little bit unfair for that person to be categorized in that category and not to follow the general advice that PCDE provides? For example, if he belongs to a very high or high risk, and to be prescribed just from the beginning metformin plus one of the novel drug categories.
Yeah. So two things. There's two parts to your question, Philip. The first part, we are not suggesting that elderly patients are at low risk. It is down in the low risk box, but it's actually separated. If you look at the algorithm carefully, it's down there, but it's separated. And the reason why we separated it from the risk is because for elderly patients, we don't think that classifying them based on cardiovascular risk is a fair paradigm or a fair premise for classification. If you do, they will be at a very high cardiovascular risk. But we don't think using cardiovascular risk as a justification for classification is fair for the elderly. And the reason is that most of the elderly patients we are focusing on here, dying is not their main worry. They are not concerned about dying. Most of them are not concerned about developing a heart attack or a stroke or kidney failure. Most of them are worried about a good quality of life. So what's the point, given all the wonderful GLP-1 receptor agonists and SGLT2 inhibitors to an 85-year-old frail patient who is housebound to prevent them getting a heart attack or a stroke? And these drugs are going to get them a lot of polyuria, polydipsia. They'll be waking up, several times to be multiple urinary tract infections, thrush down below, itching, and dehydration, GI side effects from GLP-1, that would just compromise their quality of life, even though it will prevent them getting a heart attack or stroke and heart failure, which they are not worried about because they'll be dying soon anyway. So that is the reason why we took them out of the cardiovascular risk categorization. So that's why it's out there. It's not low risk, but it's just separate. The second part of your question was the age. Again, yes, it's a good point. Age over the age of 65, is a cutoff, but we didn't just say age. If you see the lower of the slide, I said age over 65 and frailty. Frailty is the key driving factor of your choices. Like you said, somebody can be age 65 and enjoy a healthy lifestyle. So for that patient, their targets will be similar to a younger patient. And you can give them all the GLP-1 receptor agonists you want, because their option or focus of treatment will be to prevent cardiovascular disease and prevent death. So yes, they will benefit from GLP-1 receptor agonists. And they just as effective in over the age of 65 compared as they are under the age of 65. However, if you've got somebody who is above the age of 65 but is severely frail, then you've got to choose your options very carefully based on their priorities of treatment.
Thank you very much for this clarification. So, in fact, we're talking about a combination of the age criterion and the frailty criterion.
Yes.
And I guess that is always up to the treating GP to decide whether this particular patient falls under this category or not.
Yes, yes.
Based on the individual patient. So I'd like also to take some questions that's from the audience. So I can see one question here that's saying that at the I'm translating that now into English. At the recent EASD ADA consensus, metformin lost its position as an initial treatment in type 2 diabetes patients.
Yeah.
Would this have any effect on a future update of the PCDE consensus sentiment?
No, no. It's a straightforward no. And the reason I say is that we are always ahead. We still maintain, we're not taking metformin out unless the patient doesn't want polypharmacy. And the reason we are saying that is because so the justification for the ADA EASD consensus report is for a patient with established cardiovascular disease whose A1C is well controlled, why do you need metformin? Metformin does not prevent recurrent cardiovascular disease. You can start with your GLP-1 receptor agonist or a SGLT2 inhibitor. That's fine. I get that. But what we are saying is that in primary care, we are not just worried about recurrent cardiovascular disease. Okay? These patients with type 2 diabetes, if you don't aggressively control their glycemia, they end up with microvascular complications as well. And indeed, we are seeing recent publications that are showing trend analysis over the past 2 decades that are showing that in the past 20 years, cardiovascular disease in people with type 2 diabetes has been decreasing. But for whatever reason, we don't know, microvascular complications are increasing. We don't know why. So we don't want to take our foot off the gas, okay? For somebody with type 2 diabetes, we don't want to compromise glycemic control. Metformin still has a place, but we are not saying metformin ahead of SGLT2 inhibitor or GLP-1 receptor agonist in patients with established cardiovascular disease. No, that's not what we are saying. What we are saying is metformin plus GLP-1 receptor agonist, the two together, early combination therapy, so that we can prevent therapeutic inertia, not just for glycemic control, but also for the microvascular complications and other complications that come with diabetes. So no, we are not going to change our position. Metformin will still be there, but together with others, not instead of others.
Thank you. So your answer was really clear. I think that the throne is to be shared between the metformin and the neuro drug categories. Another interesting question that I can see here is the following. Do you suggest that we should be also aggressive with the other risk factors, especially hyperlipidemia in patients under 40 with type 2 diabetes?
Oh, fantastic question. We were silent on that because the evidence is already there. So for patients with a very high risk of cardiovascular disease, those who have had an event already, you already go for your high intensity, statins anyway. Atorvastatin 80, that's what everybody does. If the patient has had an event, you go for your high intensity statin anyway. That is already in all the guidelines. When they don't have, an event already, the question is whether if you go very hard on them, you get a legacy benefit that you see with glycemic control. That we haven't seen that, and we are not suggesting that. It would be bold to suggest that you should be giving, your very, very potent cholesterol-reducing agents like PCSK9 inhibitors to somebody who hasn't had an event and hasn't had, familial hypercholesterolemia. I think it would be a very expensive push. So for that, we are not recommending that. Statins, you just go as the statin guidelines would suggest.
Okay, thank you. Thank you so much. Another question from the audience is, what do you think was the most important driving power behind the development of these consensus guidelines, if you were to choose one?
Yeah, three things. One, simplicity. We wanted simplicity, which is why we categorized our patient populations to very, very high risk and high risk. We didn't want too many classifications: high risk, moderate risk, low risk, too many complications, too many subgroups, and we'll be confused in primary care. We got other things to think about. So simplicity was one driving factor. The second driving factor is therapeutic inertia. We know that in primary care, 50% of the causes of therapeutic inertia is due to the healthcare professional. Okay, so we focus, addressing therapeutic inertia with double initial combination therapy to prevent the therapeutic inertia. And the third driving factor was multimorbidity, because our patients don't just have diabetes alone, they have diabetes and other things. So when we're choosing a drug, we choose a drug that will treat the diabetes and the other things, and not to forget about the other things. So those are the three driving factors.
Very clear, thank you. Are there any other questions from the audience? Yeah, I think we'll have one more question. Okay, so let me check. Okay, so another question that we have is that, is this consensus statement valid for the entire type 2 diabetes population, or are there any exceptions or limitations?
So this is for type 2 diabetes. It's not type 1, and it's not GDM. It's for type 2 diabetes.
But for the entire population of type 2 diabetes, right?
Yes, yes.
No exceptions, no limitations.
It captures, all the, so basically we just split patients in type 2 population into very high risk and high risk. Simple. Very high risk are the 4 categories I talked about. Those with atherosclerotic cardiovascular disease, those with heart failure, those with chronic kidney disease, and patients under the age of 40. The rest are all either at high risk or they are elderly frail. And that's basically the whole of type 2 population.
Perfect. Okay, is there another question? Okay. I can see no other question for the moment. So, okay, so since there is no other question, I would like to thank you very, very much once again, Professor Seydu, for this excellent presentation, very clear guidance that you have provided us, very clear take-home messages that I truly hope that they will be really viable for our primary care audience, since we don't have, we don't have guidelines for type 2 diabetes in primary care. We used to have that, and they were updated for the last time in 2015. So we have a considerable lack of recommendations and guidance in primary care. And I think that this PCD statement could really help Greek primary care physicians better manage their patients. It was truly an honor to have you with us tonight, and thank you very, very much on behalf of all Greek GPs.
Thank you very much. Thank you. Thank you.
Καλή νύχτα σε όλους. Σας ευχαριστούμε πάρα πολύ για την ενεργό συμμετοχή σας και την παρουσία απόψε. Καλό βράδυ και καλές γιορτές να έχετε.
Thank you. Thank you.
Bye bye.
Bye.